Here we go. Okay, well, I'm glad to be back with you this week. I really had a great time this past Thursday. I do enjoy being in the classroom. I do enjoy interacting with the students. So it was a wonderful opportunity to spend the afternoon with you to discuss, strategic planning. And today we're going to shift gears to program planning. But before we do that, I wanted to ask, do you guys have any questions or thoughts related to the material that we discussed last week? No? How do you feel about it? Do you feel good about it? Do you feel like you have, again, we just did one session on strategic planning. I mean, as you may know, we actually currently we offer a semester-long course in strategic planning for students, really for students in the health administration concentration and for other students as an elective. So what we did last week was a very condensed, high-level version, introduction to strategic planning. But you feel at least that you have an introductory knowledge of what strategic planning is and how it works. Okay, very good. So again, last week we focused on strategic planning or strategic management, which is really planning for the future of the organization, identifying strategic priorities, developing goals and objectives for each strategic priority area. So interestingly, this morning, I was at the Valley Brook campus, ETSU's Valley Brook campus in Gray. Today, the university's academic council, which is like the highest committee at the university level that oversees academic program development, they're having a full day retreat, planning retreat. So I was at the morning session and I left around lunchtime so I can be back here on this campus for class. But what we did this morning was really work on 3 areas. Identify strengths, we call them barriers instead of weaknesses, and then opportunities in 4 strategic priority areas for the university related to academic programming. And those 4 strategic priority areas are undergraduate admissions, graduate admissions, new programming and new modalities of program delivery, and the 4th one is online education. So for each of those, again, priority areas, we created working groups, and each working group identified, as I mentioned, strengths, barriers, dash weaknesses, and opportunities related to those areas. Again, as a mechanism of really we were doing an internal environmental scale, right? Which is part of that first phase of strategic planning that we discussed last week. So all of this information will be, gathered and utilized to further develop the university's planning and budgeting processes. So that was interesting that was going on today, just 1 week after we had this discussion last week. But in addition to strategic planning, again, which is at a very high level for the organization overall, public health managers across all disciplines frequently engage in health program planning, meaning in developing, implementing, and evaluating health policies, health interventions, health programs to really address priority health issues in the communities or the populations that they serve. So this is true for healthcare administrators, for epidemiology managers, for community health leaders, environmental health managers, across disciplines, regardless of the disciplines. Public health, again, leaders frequently engage in program planning. This is a very important function of any public health leader. So it's really important that we understand how program planning, management, and evaluation works. What does it involve? Understand the process and learn some specific skills related to this important, function of health administration. And because this is a pretty important topic and involves multiple aspects, planning, management, and evaluation, we will cover it over 2 weeks. Okay? So really today we will focus more on planning, some management, then continue our discussion of program management and focus on program evaluation next week. So the PowerPoint slides that you have that were posted to this week's session, we will actually cover those this week and next week. So there is not an additional set of slides for next week. Is that true, Dr. Bailey? Okay. Yes. Okay. Any questions before we get started? So our objectives then for this afternoon and for next week, it's one big, objective, one big competency, which is to apply the principles, again, of program planning, development, budgeting, management, and evaluation to address priority health problems. And under this competency, we will focus on 2 objectives. First, we will describe, using an ecological framework, how the different determinants of health contribute to health outcomes. And second, we will describe the steps and the procedures related to program planning, management, and evaluation. So our first objective, again, is to identify and describe how the different determinants of health influence population health outcomes, and to do so using a broad ecological framework. Now, I suspect that you have seen this slide before, right? At the beginning of the semester. I would even venture to say that it was during the very first class session. Okay, do folks remember this? Okay. So Dr. Beatty, during the first class session, highlighted the different determinants of health. A determinant of health is a factor, okay, that influences health status or health outcomes. And we categorize the determinants of health into 5 groups. Okay? Now, of course, the determinants of health are interrelated and impact each other, but for ease of presentation and communication, we do categorize them into 5 groups. And you can see those 5 groups on this slide. Okay? The socioeconomic or sociodemographic determinants of health, the biological-genetic determinants of health, the environmental determinants of health, the behavioral or lifestyle determinants of health, and then the healthcare or access to healthcare determinants of health. Okay? So 5 main factors that influence the health of any population across the globe at any point in time. So let's briefly discuss each one of them, starting with the socioeconomic or sociodemographic determinants of health. Can you give me an example? What goes into this circle here? What are... I'm sorry?
Education level?
The educational attainment or the educational level of the population. Occupation or job.
Household income.
Household income. Cultural factors. Excellent. Okay? Yes?
Political environment?
Political environment. Excellent. Okay? And we will come back, to those factors in a minute. But those are the main, socio-demographic factors. Again, education, income, occupation, culture, political environment, etc. How about individual behaviors or lifestyles? Can we think of examples under this umbrella?
Like smoking.
Smoking.
Sedentary lifestyle.
Sedentary lifestyle. Excellent.
Diet.
Diet. Wonderful.
Sexuality.
The sexual behaviors. Excellent.
I was about to say multiple sexual partnership.
Multiple sexual partnerships, I guess, related to sexual behaviors. Yes. Excellent.
Religion? Or would that be more social environment?
I think that would be more, under religion, culture would fit more under the social environment. Other tobacco use, okay, in addition to smoking. For example, in the region here, chewing tobacco is quite common. E-cigarettes now is quite common. Substance use and abuse, right? A lot of you selected opioid use as your project topic. So all of that falls under individual behavior or lifestyle. Environmental factors. What goes there?
Overcrowding.
I'm sorry?
Overcrowding.
Overcrowding.
The built environment.
The built environment. Excellent.
Pollution.
I'm sorry?
Pollution.
Pollution. So that can be air pollution, water pollution, soil pollution. So there are different, right? Forms of pollution. Other factors in the physical environment.
Could it be natural disasters?
Natural disasters can certainly impact the physical environment, flooding, storms, hurricanes, and we've just seen that, for example, in the Carolinas.
Accessibility
Accessibility.
to like healthcare, accessibility to healthy foods, accessibility to anything.
So accessibility to healthcare would go under this determinant.
Maybe like wildlife biodiversity, so like what insects you have in the area that might carry disease or something.
Exactly, the connections between the ecological environment and the human environment. Housing conditions. Okay. When I lived in Baltimore, for example, a big issue in the old houses was lead paint. So that's a well known environmental factor that can have detrimental effect on health. You were going to
How
say
about
something.
climate change?
Climate change. Excellent. Okay. Access to quality healthcare. So access is a very broad concept. Okay. Access to healthcare that really embodies different constructs. So what all goes into access to healthcare? Funding for healthcare services. What are the? I'm sorry.
Personnel, healthcare personnel.
The availability of healthcare personnel,
Insurance,
particularly again in rural areas.
insurance coverage.
Health insurance coverage. Is that what I heard?
Yeah.
Wonderful health insurance coverage really determines whether healthcare services are affordable or not, right? So affordability is an important dimension of access to care.
Equity.
I'm sorry?
Equity.
Equity in the distribution of health services. Availability of services in a particular area. I mean, whether clinics are actually available or specialty services are available or specialized providers are available in certain communities. So what does it mean that those different determinants of health are related? What does that mean? We talk about each one of them separately, but there are really arrows, going all around. What does it mean that they're related?
Well, it's kind of like if you have a high household income or you're in a nice socioeconomic status, you can affect your physical environment by having the resources and the funds to change it, either as an individual or as a community.
Okay. Did everyone hear that? Okay. So by having the education, the income, okay, that largely determines where we live, whether or not we have access to health care, whether we can afford to buy, healthy food options and prepare healthy food options, and so on. Okay, so I'll give you an example. I'll give you my example. Okay. Obviously, I have high, educational attainment, a great, job. Okay. Because of that, and because of my, husband's, again, education and job, we're able to live in a very nice neighborhood, in a relatively new home, right? And we can actually go walking every evening because there are sidewalks in our community and the streets are well lit and it's a safe environment, right? And I can stop by the fresh market on my way home and pick up organic, fruits and vegetables for the family. And yes, I may be at a high risk genetically for breast cancer or colon cancer, which I am, because they run in my family. But because I have health insurance, I can get screenings frequently and make sure that if and when that cancer decides to appear, it's going to be caught early and treated effectively, right? So compare this to another person who was born into very difficult social circumstances, dropped out of high school, lives in government-subsidized, suboptimal housing, where shootings occur in the neighborhood every evening. They don't have access to safe walking trails. They cannot afford membership in a gym. A $2 burger from McDonald's sounds wonderful because it's cheap and easy. They work 2 part-time jobs, but because they work part-time, they don't have access to health insurance, and therefore they delay receiving their preventive and primary care services. I can talk to this person all day long about the importance of exercising. I can talk to them all day long, educate them all day long about the importance of healthy eating. I can counsel them all day long about the importance of getting their annual physical exam. But unless they have the resources needed, the education, the income, the job, that would make it possible for them to adopt those healthy behaviors, or to access health care, or to live in a safe environment, they're not really going to be able to adopt those behaviors. So I can preach to them all day long. And they're going to get it. I mean, they're going to have the knowledge, they're going to have the awareness, they're going to have the education. But without the resources, it's very difficult to make the change. So that is why the social environment, the socioeconomic factors are considered the overarching determinant of health, meaning that they affect all other determinants of health. And that's why interventions, policies or programs that are focused simply on health education tend to have a very limited impact in terms of changing behavior and the changing outcomes, unless they simultaneously seek to address those underlying socioeconomic factors. Does that make sense to folks? And I say this because when you are working on your projects, many of you will be tempted to propose a health education program of some type as your intervention. Why? Because there's a lot of examples in the literature, and those are easy to do. Okay? We're gonna do a health education program on college campuses. You see that a lot in the projects. We're gonna do a health education program in high schools to educate, kids about the dangers of smoking or alcohol use. That's all great, but if that's all you're proposing, I can assure you that it will be unlikely that you will achieve your objectives for that program. And that neither Sylvester nor Dr. Beatty are going to like it a lot. And that making that A will be difficult. They're going to really want to see you. It's fine again to propose a health education program, but in addition, how are you going to change some aspect of the environment in which your priority population lives and functions to facilitate their adoption of that healthy behavior that you want them to adopt? Okay? That's a more difficult question, a more challenging question, but that's where our thinking needs to be as public health practitioners. Okay? Any questions related to this? So another way of presenting this slide is in the format that you see here in front of you. This is the format that Healthy People 2020 uses to present the determinants of health. Now, let me see how many here in the room, how many of you have heard of Healthy People 2020? Okay. So Healthy People, what is Healthy People 2020?
It's a 10-year national plan to improve the lives of Americans. But it's over its 10 years.
Exactly. So Healthy People 2020 is in a way the national strategic plan for health improvement. It is developed, championed by the Department of Health and Human Services, the US DHHS, and it identifies priority areas and objectives for a range of health indicators, again, for the nation to achieve. Prior to Healthy People 2020, we had Healthy People 2010, and prior to that, Healthy People 2000, so it's a 10-year, again, strategic plan. Currently, we're under HP 2020. And so in developing the objectives for Healthy People 2020, they utilized the following model to depict the determinants of health. It's the same idea like we just discussed. The idea here is that we all have innate individual traits, okay? I'm a certain age, a certain sex, a certain race, and again, I have certain biological or genetic factors. So those are individual traits that are innate and pretty much non-modifiable, okay? To a large extent. But it's important that as an individual, I'm aware of them because again, they can increase my risk for certain health conditions. So for example, as my age increases, again, my risk for different cancers increase. So it's very well known that age is a risk factor for cancer. And those innate traits can also be affected by our individual behavior. So this is, our lifestyle. But you can clearly see here how individual behavior falls under or is impacted by our social, family, and community networks, okay? Which in turn are impacted by our living and working conditions, our socio-demographic determinants of health. They impact our community where we live, they impact our individual behaviors. And then ultimately, as was suggested, even living and working conditions are impacted by the broad political, social, and economic policies nationally and across the globe. Okay? So the idea of presenting those determinants of health as concentric circles is really to emphasize the fact that they, impact one another, and really for interventions, for policies and programs to be effective, they have to cut across the different determinants of health. That's why we have this arrow that's going, across those concentric circles. So the most effective interventions, okay, in changing outcomes are interventions that address the multiple determinants of health. Okay? So again, as you are thinking about interventions, policies and or health programs for your project and for your internship later on, and in your jobs later on, it's important that you keep this model in mind and that you think of interventions again that address the multiple determinants of health in order to have the most impact on behavioral outcomes, on disease prevalence, morbidity and mortality, on quality of life, health equity, and other important population health outcomes. But again, that's really the model underlying the Healthy People 2020 plan and objectives. Questions about this? So it's really just two ways of saying the same thing. This is the same as this one. They're just presented differently. Questions about determinants of health? Okay. So now that we have, hopefully, I know this was discussed earlier, I just wanted to reiterate those concepts because they are important. Now that we have a good understanding, hopefully, again, of the determinants of health and how they affect one another, I think we can begin, our discussion of the program management cycle. Now, 2 weeks ago, Ms. Amy Weber was here, and Amy discussed what? What was the topic of her session? Leadership and partnerships, right? So she talked about coalition development and other types of community partnerships. I'm sure she talked about why it's important to develop partnerships. What are the advantages of working collaboratively as part of a partnership instead of as individual organizations and groups? So, again, keep that in mind because really program planning should start before we even talk about what problem we want to address, what program we want to develop. We should be doing, two important things. We should be assessing the needs of our community to determine what the priority health problems are, and then we should be mobilizing community partnerships, again, like Ms. Weber discussed, to help solve those priority health problems through policies and programs. So how do we assess community needs? What does that process involve? What all goes into a community needs assessment?
So it involves bringing together stakeholders in that community, okay, so everyone has a stake in that issue, then they analyze the issue, then they look at the assets and the needs of the community, then they can profile ways out of those challenges.
Exactly. You got it. So assessing community needs really should involve the different community stakeholders. It should not be, again, an exercise that any one individual conducts by himself or herself. It does involve reviewing the quantitative data, so epidemiological data about the health indicators for that community. Prevalence of different diseases, prevalence of risk factors, morbidity and mortality trends. We review all of that quantitative epidemiological data as a first step of the community needs assessment, but we don't stop there. We have then to convene, the different community groups and stakeholders, review the data together, seek their perceptions, and again, get buy-in when identifying what the priority health problems are. I always give this example when I lived and worked in the state of Mississippi. I did quite a bit of research in the Mississippi Delta, which is one of the most impoverished areas of our nation. And we knew from the data, from the statistics, that cardiovascular diseases, for example, were highly, highly prevalent in the Mississippi Delta because of the risk factors, to cardiovascular disease that were, again, disproportionately high in those, poor and disadvantaged communities. So we were thinking that cardiovascular disease is really the priority health problem for the Mississippi Delta. And that's what we should be getting funds for and doing, programs about. Now, thankfully, one of my colleagues at that time, she was the community health, person on the team. And she said, we really, before we start developing any programs or seeking funding for new programs, we need to go to the Mississippi Delta and we need to convene, teachers and policemen and students and business owners and discuss with them what they believe their priority health problem are. So we did that. We went there and we convened a couple of focus groups, and the only thing that the people wanted to talk about was the fact that on one of the intersections in their neighborhood, there was no stop sign. That was the priority issue in their mind. And it was not until we, the researchers, helped them get a stop sign for that busy intersection that they were willing to start listening to us talking about cardiovascular disease. So if we had went in and told them, this is your problem, cardiovascular disease, this is what we're going to do, they would have ignored us. But because we took the time to listen to what they perceive, what they believe their problems are, and actually worked with law enforcement to help them get a stop sign, we established, that trust, and they were willing to partner with us to begin to address cardiovascular disease in their community. So Comprehensive community needs assessment should include review of the epidemiological data as well as qualitative input from key stakeholders in the community. Once we identify the priority health problems for our community, then again, we need to mobilize a community partnership to collectively, through collective action, seek to address that problem. And again, that relates to what was discussed 2 weeks ago. And what will be the first part of your project, developing a coalition proposal to address your identified priority health. Questions about that? Yes.
Well, this may not be applicable in the US, but what happens in communities where there are no epidemiologists to work with? So like going to a community where there's child health issues, or they do not have a database to tell us the number of children who died per day or per month. And we want to conduct needs assessment in that place.
So the question is, so what would happen in communities where we really we don't collect, we don't have good epidemiological data to begin to identify what the priority health problems are? Any thoughts about that? Anyone has had any experience in this area? Working in a community, again, where really there's little or no epidemiological data?
You get it yourself.
I'm sorry?
You go out and get it yourself.
So,
What I
so,
had to do for my community.
so that's certainly, one approach is perhaps one of the first, steps can be to seek maybe a small grant or other type of funding to do some baseline data collection or some preliminary data collection to help, again, inform the development of your programs. And that can be done, again, using surveys or using, focus groups, town hall meetings, and other qualitative approaches.
So the reason why I asked you that, my experience with that is that we eventually use qualitative surveys, but I was wondering that it wasn't based on epidemiological data. Does it mean that process was not properly done since it was just qualitative?
No, qualitative data, if collected appropriately, can be very rich and can provide a very useful, source of information. We do a lot, for example, Dr. Beatty and I, really almost all of our work is what we call mixed methods, where we integrate, quantitative and qualitative data. Now, where having the quantitative data will help is, again, helping to establish a baseline for developing your objectives, which we will talk about in a little bit, to see if really you have made a change or not. In the absence of baseline quantitative data, it's hard to measure and document a change. But qualitative data certainly can be very valuable. Other questions? Okay. So when we talk, I'm going to skip a few slides and come back to these. Okay. So I just skipped, to slide 25. I believe I decided to change the order just to enhance the flow of the presentation today. So when we talk about interventions, an intervention is really a broad term that includes both health programs and health policy. So development of a policy is a form of intervention, and development of a program, whether it's a health education program or other type of program, is also an intervention. Now, in the public health sphere, we distinguish between two broad types of interventions: preventive interventions and treatment interventions. Treatment interventions are really more in the medical field. Okay, so developing, effective treatments for different health problems, conducting clinical trials to evaluate, new treatments relative to the current, standard of care. In public health, we're typically more focused on preventive interventions and less so on treatment interventions. And within preventive interventions, we also distinguish between those that are population-based versus those that are clinical or individual-based. Okay? So clinical prevention targets individuals, whereas population-based prevention targets populations. So can you give me an example of a clinical prevention measure or a clinical prevention intervention?
Immunization.
I'm sorry? I heard something.
Immunization.
Immunizations, and they are clinical preventions. Sometimes when we do mass immunization campaigns in communities, they can cross into population-based prevention, but certainly immunizations or vaccinations are a very important, clinical prevention measure. Individual counseling, excellent. Screenings, okay, so all forms of screening, right? Screening for, again, cancer, screening for high blood pressure, screening for cholesterol, etc. All forms of screenings fall under clinical prevention interventions. Yes, ma'am?
So what about things like hand washing? Would that also be a clinical prevention, or would that fall under something else?
So hand washing is typically a population-based prevention.
Okay.
So you would really do education programs for communities, for schools, for hospitals, for other institutions. Typically, you're targeting groups at a time to educate them about the importance of hand washing. With clinical prevention, the difference is you deliver the service to one individual at a time. Okay? So let's say a mammography test for the early detection of breast cancer is a clinical prevention measure. A colonoscopy for the clinical detection of colon cancer is a clinical prevention measure. A mass media campaign, okay, to encourage healthy eating or to promote exercise would be a population-based prevention intervention. Other examples of population-based interventions, targeting populations. Yes.
So maybe the anti-smoking commercials that they have on TV?
Anti-smoking commercials on TV, excellent.
Condom distribution.
Condom distribution, excellent.
Like any form of just like health education be considered population-based?
Any form of health education delivered on a large scale, yes.
Literacy campaigns, would you count those? Because it's sort of a social determinant?
Literacy campaigns, again, particularly if they're delivered to groups at a time. Restaurant inspection. Water testing to ensure the quality of the water that we drink. So there are a lot really of public health measures that we don't see that sort of happen behind the scenes. Okay. But I filled this bottle, from the water fountain. Someone is assuring that that water is drinkable, right? That's a public health measure, right? I got this sandwich from a restaurant on my way here. Now you're all gonna be hungry because this is a really good sandwich. But someone, the public health agency, the local health department, through its trained inspectors, ensured that the restaurant was practicing, safe and hygienic methods to ensure the safety of the food that I'm eating, right? So all of those are population-based. Now I'm keeping it here without a fridge. It has turkey and cheese in it, so it's soon not gonna be safe. But it was safe when I got it. Now, was there a question there?
What did you say the example for treatment intervention was?
I'm sorry?
What did you say the example for treatment intervention
For
was?
treatment interventions, so this is really any procedures or drugs, the development of new drugs or new procedures to treat different diseases. Okay. Now let me ask you this: which of those three, treatment interventions, clinical prevention, population-based prevention, which type has the greatest return on investment? Population-based prevention. Okay. The greatest return on investment, meaning the greatest cost effectiveness, the cost relative to the impact is highest. Yes, sir.
Excuse me, can screening also be under population-based prevention, like a massive screening of in the community? You realize so many
Mobile vans, or
can it also be under population-based prevention?
yes, certainly. Yeah.
What about smoking cessation program?
Smoking cessation programs. Again, if they're developed really to population groups, then it's more of a population-based prevention. If it's individual counseling for smoking cessation in a clinical setting, then it falls under clinical prevention. Now, out of those three, which one has the lowest return on investment? Treatment interventions. Okay? They tend to be, again, very costly and targeting specific individuals. So really what we want to do is we want to emphasize population-based prevention, do more clinical prevention, and do less treatment interventions. So when we think about the three levels of prevention, primary prevention, secondary prevention, and tertiary prevention, where does primary prevention fall primarily here? Population-based prevention is primary prevention. Okay? Clinical prevention is typically secondary prevention. And the treatment interventions are typically tertiary prevention. So do we know the difference between primary, secondary, and tertiary prevention? So primary prevention, okay, we're trying to stop the disease before it happens. You hand wash to stop the spread of germs. Okay. You inspect food and restaurants to prevent salmonella infections. You treat water, again, to prevent disease. You put fluoride in water to prevent dental caries. You immunize to prevent the onset of disease. That's primary prevention. Prevent it, stop it from occurring the disease. Secondary prevention is you're detecting disease at an early stage, where it is easier and more cost-effective to treat. Okay? So at this point, when we're screening, when we're doing a mammogram detects breast cancer at an early stage. It does not stop the breast cancer from occurring. The breast cancer has occurred, the mammogram is finding it early, when it's still the size of a mustard seed. The colonoscopy finds colon cancer or rectal cancer early. Okay? But does not stop it from occurring. So secondary prevention is for the purposes of early detection of disease before symptoms occur and when treatment is most effective. tertiary prevention, symptoms have occurred. And what we're trying to do through those interventions is to prevent further disability and deterioration. Okay? So again, keep that in mind. Primary prevention, secondary prevention, tertiary prevention, primary prevention being the most cost effective. Any questions about that? No? Okay. So again, we already covered those slides. Population-based interventions, they address priority health problems at the community level. Clinical prevention, here are your examples, screening, counseling, all of the examples that you already provided. And then how those relate to primary, secondary, and tertiary prevention. Okay. Any questions about anything we've discussed so far? Determinants of health, types of interventions, levels of prevention. Go ahead.
Not so much a question, but kind of an observation. There seems to be a disconnect between incentives for fixing some things. So the incentives for most healthcare systems, it seemed like, would be towards treatment interventions. So some kind of disconnect going on there between public health and healthcare systems.
Yeah, so exactly. So what Matthew's saying is that there seems to be a disconnect between public health and healthcare systems. So, and I know this, your online colleagues may not be able to see it. But basically, this is the population health pyramid. Population-based public health services are at the very bottom here. Because those are services that everyone needs at any point in time. So everyone needs clean water, safe food, clean air, vaccines, etc. And then clinical prevention is the second level. Most everyone in the population at any point in time needs some type of clinical prevention. And then primary medical care, there are fewer people in the population at any point in time who need primary medical care services. So that refers to routine healthcare services, services for the common cold or for the flu or other common conditions. And there are very few people, very few at any point in time, who require secondary or tertiary medical care, meaning specialized treatments, open heart surgery, high-tech procedures. Okay? So you would think that in any population, most resources should support population-based public health services, followed by clinical prevention, then primary medical care, then secondary and tertiary medical care. However, in our nation here, when we look at resources, where we spend our resources, where we spend our health dollars, this is how the pyramid looks like. Can you guys see down here? This is how it looks like. We invest the least dollars in population-based public health services. We invest a little bit more in clinical preventive services, more in primary medical care, and a lot in secondary and tertiary medical care. So over time, as a nation, we've really allocated, again, our resources, our health dollars, opposite to what the population health needs are. And this, in large part, is responsible for our high spending as a nation relative to our not so optimal health outcomes, which is what Dr. Hale will be discussing in a couple of weeks. Okay. But that goes back, to what you're saying, Matthew. We're starting to realize that. We're starting now to put incentives and programs at the national level in place to encourage the shifting of resources to where, again, we're investing more in prevention and less in treatment. But it's going to take really time for us as a nation to begin to see the impact of this switch. Nations who have the best health outcomes and lower costs, their spending pyramid tends to be more aligned with their health need pyramid. The farther the gap between the spending pyramid and the health need pyramid, typically the poorer the population health outcomes and the higher the national health bill. Any questions about that? Okay. So I think this is a good time for us. Yes.
How soon do you think this trend will be reversed in America, and what are those factors that are currently preventing or that might slow it down?
So the question is, how long would it be before this trend reverses? I would bet it won't be during my lifetime. I don't know if Dr. Beatty agrees. I mean, again, it's starting to shift, but shifts like that take decades, and not years. So I'm encouraged by the movement. We're moving in the right direction, but it's going to take a lot of time and effort and political will and advocacy from informed public health professionals like you all.
So what are some of the barriers to flipping this? I mean, we talked about return on investment the first week, and the numbers are there for the few things that we've got the data on, but what are some of the barriers to flipping towards more population health or public health work versus?
I think a lot of people are more comfortable with just saying, oh, I'll just get treated for it rather than being told like what they're doing wrong, like in their lifestyle. Like they would rather just say, I enjoy smoking, so I'm gonna be okay with getting lung cancer and I'll just get treated for it rather than being told, hey, smoking's bad, you shouldn't do it.
You might not get lung cancer, right?
Right. And people also think that like, well, it might not happen, so like why should I worry about it?
Yeah, so there's that issue of changing behaviors is really tough. And we love just like, give me a pill. If there was a pill out there to solve every problem, magic pills.
I was gonna say that healthcare is such a huge industry and a lot of it's privatized, so it brings in a lot of profits, and so moving to something that may not be profit based and maybe more health based may make interests very angry and they may fight back against that.
So we are built on capitalism. We're capitalists. We like our capitalism. That's a big piece of it. A lot of when we compare ourselves to other nations that are listed higher above us, they typically have more socialist view and socialist government compared to us. Okay? Or Matt?
Yeah, just going off of what he said, I mean, so there's no real incentive for some of the health systems to engage in population health. Because if they did, they would, if they started shifting resources away from treatment and went into population health, they wouldn't be receiving payments like they would from insurance companies from the government, so they're going to go out of business.
So if nobody walked in their doors, they wouldn't have a business model.
And that's the challenge that health systems are actually facing now. So now, for example, a major government program, in a way, penalizes hospitals for hospital readmissions. Okay, so if you discharge a patient and the patient is readmitted to the hospital within 30 days, okay, hospitals are penalized for that. Okay? But that's to encourage, again, more community-based care and more preventive care, and to limit, to reduce what are known as preventable hospitalizations. So the hospitals are really trying to reduce preventable hospitalizations because, again, they're going to be, it's better for their patients and they're going to be financially penalized for them. But at the same time, reducing them means fewer admissions and fewer payments. So yeah, that's
and we're seeing a shift from inpatient services to outpatient services. So as technology evolves, we would rather be, as like any of us, would rather get a procedure and then go home in your own bed in your pajamas and heal instead of being in the hospital. So we're seeing a shift, and we're seeing hospitals become systems that also have doctors and clinics, so that they are having to evolve with this change. Can I see another? So yeah, that is a challenge, kind of playing off that. We'll talk about this a couple of weeks from now, but what is the big public health advocacy group lobbying firm? Anybody? Yeah, no. What are the big hospital lobbying organizations or organizations?
HCA. HCA. The Healthcare Corporation of America. HCA.
HCA, yes. The American Medical Association, the American Hospital Association. We have the American Public Health Association, but they're very small in the dollars they have for lobbying versus these other organizations. So that plays a role in what's heard louder by politicians. So not to say it's impossible to flip this, and we're moving in the right direction. There's a lot of force we have to get through. Paradigm shift, as we like to call it, to really switch this.
Again, the more trained and informed public health professionals there are, the louder we can be, right? And to make our case to policymakers, to mobilize communities for action, to make people aware of what happens behind the scenes. I mean, we take things like this for granted. This is not to be taken for granted. In many, many countries around the world, I mean, they still have to boil the water before they can drink it. Okay? So really raising awareness about everything that public health does is important. Okay, other thoughts before we take a short break? Because I think this is a good time to stop before we start discussing the management cycle of public health programs. Okay, why don't we take a 10-minute break. Okay, that's maximum 10, not minimum 10. And we will reconvene at 2:15. Thank you. Okay. So now again that we have a pretty good context really of, again, the determinants of health, how they affect health outcomes, different types of interventions, and how they relate to spending. I think we're ready to jump into program planning and begin to discuss the different phases of the management cycle of public health programs. So overall, the management of health programs consists of 3 phases: planning, implementation, and evaluation. But just like we discussed last week, just like with strategic planning, it is not sequential, it is cyclical, okay? So what we're gonna do the rest of the afternoon today and next Thursday is really discuss each and every one of those steps or phases of the program management cycle. Okay? So we're going to start by developing a problem statement for our identified priority health problem. Then we review the scientific literature, analyze our priority health problem for its risk factors, then develop program or policy options, and select our intervention. Once we select our intervention, we develop a work plan for our intervention, including a budget. This completes the planning phase. We then move into the implementation phase and the evaluation phase. So program planning then, again, once a priority health problem is identified based on the community needs assessment, program planning involves developing a problem statement, reviewing the literature, identifying the risk factors influencing the problem, developing our intervention strategy, and developing our action plan and budget, as well as developing our evaluation plan. So actually, development of the evaluation plan occurs during the planning phase. We implement, we evaluate. Based on the findings of the evaluation, typically, as public health planners or public health managers or evaluators, we're going to make one of 3 recommendations. We're either going to recommend that our program be disseminated widely if the evaluation finds that it was successful in achieving its objectives, or we will recommend discontinuing the intervention if the evaluation finds that we were not successful in achieving our objectives, or we will recommend revising and retooling our intervention if the evaluation finds that some aspects of the intervention worked and other aspects need improvement. Okay? Which of those outcomes do you think is most common after conducting an evaluation of an intervention? Recommending that we disseminate it widely, recommending that we discontinue the intervention, or recommending retooling and revising the intervention?
Revising.
Retooling and revising is typically the most common recommendation following an evaluation, because typically, again, we will find that some objectives were achieved, some aspects of the intervention worked well, and we will identify opportunities for improving other aspects, which then offers an opportunity again for retooling and revising the program before widespread implementation. Again, we will be discussing each of those steps in detail, but any questions at this point about the overall framework that we are presenting here for program management? Okay. So develop our problem statement and outcome objective. So your project, your group project for this course includes 2 phases. For the first phase, you will develop a proposal, a coalition proposal, to address your identified health problem. The second phase of the project involves developing a program plan that includes those different steps. One of the first things that you will do is to develop a problem statement and an outcome objective. So you've heard me mention the word problem, health problem, problem statement. So what's a health problem? A health problem is an undesirable condition of people expressed in health outcome terms, such as morbidity, mortality, disability, incidence, prevalence, or other outcomes, that is likely to exist, continue to exist, perhaps get worse, unless additional interventions are implemented. So when we're defining our health problem, we're defining it in terms of at least one of those outcome measures. Okay, so we talk about reducing cancer mortality, for example. We talk about reducing the incidence of HIV, reducing new cases of HIV and AIDS. We talk about reducing the prevalence of teen pregnancy. Okay, so whatever the health problem is, we're typically expressing it in terms of one of those outcomes. So our problem statement then is a concise and accurate description of this problem or condition that we identified. The problem statement is typically 1 to 2 pages, and it includes the elements listed on this slide. Okay? So it states, it defines what the problem is that we are, again, seeking to address. It highlights the magnitude of the problem. Magnitude of the problem refers to the size and seriousness of the problem. Size is measured in terms of incidence and or prevalence. Seriousness is measured in terms of morbidity, mortality, disability, or other indicator. In our problem statement, we should identify the population or populations at risk. Okay? So again, for breast cancer, for example, the population most at risk is women, 40 years of age and older. Okay? For unintended pregnancy, a population that is at high risk is teenagers and young women, right? 15 to 16 years of age, to maybe 21 years of age. The problem statement also identifies past and future trends in the problem. So have the incidence or prevalence rates been increasing or decreasing, or are they stable over time? What's happening to morbidity, mortality? So really a visual depiction of that epidemiological data, both for the problem itself and also for its major determinants of risk factors. So we want to know what are the trends over time in our health outcome or problem and in the underlying factors. So most of this information, again, comes from the epidemiological literature, the surveillance, the public health surveillance systems. You will summarize it and present it as part of your problem statement. The problem statement typically is going to include some narrative, it's also going to include some visuals, charts or tables, again, to better visualize the trends and the issues at hand. The problem statement will conclude with developing our desired outcome objective. So the outcome objective is the level to which a health problem should be reduced and or maintained within a specified time period. So if our health problem is, again, breast cancer mortality, then our outcome objective would be something like to decrease breast cancer mortality among women 40 to 75 years of age in the state of Tennessee from the current baseline level to the future desired level. If our health problem is children born with NAS, neonatal abstinence syndrome, then our outcome objective will be something like, again, to reduce the proportion of infants born in Washington County with NAS, with neonatal abstinence syndrome, from the current level in 2016 or 2017 to the lower future desired level by the end of the intervention. Now, why did I say from the current level in 2016 or 2017, not from the current level in 2018? Because we don't have that data yet. Typically, if we're lucky, our most current data is going to be 1 to 2 years, sometimes 3 years old. So we would use that as our baseline. Last week, we talked about SMART objectives. So this is just reinforcing that. When we are developing objectives for our health intervention, those objectives must be SMART, meaning specific, starting with an action verb, and identifying our priority population. The objective should be measurable, so we can document the change or lack of change over time. It should be attainable, so we want our objective to be ambitious, but at the same time feasible, especially given what our resources and time frame are. Our objective should focus on the results or the outcome, not the activities, and it should identify our time frame and target date for achieving the objective. Okay, so SMART, specific, measurable, attainable, results-oriented, and timely. So keep that in mind, okay? So now we're gonna work on an exercise together. And again, you can work with your neighbor. You have here 3 objectives, hypothetical objectives. And your charge as a program planner is to examine each of those objectives and determine, this is a SMART objective, I'm gonna keep it as is, or this is not a SMART objective, it's missing certain elements, I need to revise it, add those elements to it to make it a SMART objective. So again, we'll take a few minutes to work on this activity. Examine each objective relative to the SMART criteria. If it's good, leave it alone. If it's not, rewrite it, please. Okay? Go.
I agree. It is the small increments.
This is what you're looking for. Again, if you want to refresh your memory, this is what you're looking for.
If I had left it, this is our section online. We messed up.
Now don't touch it. It's fine. It's fine. Don't touch it.
Also, doesn't include when they're starting.
Okay, it may help if we do the first one together, and then we sort of have a better idea what we're looking for. So let's start with the first one. Braden, you want to read the first one to us, please?
To increase the measles immunization rate among 2 to 3 year old children from 70% to 90% by 2018.
So what did you guys think of that? Well, let's start with what's good about it. What aspects of the SMART objective it contains? It gives the baseline level, but it's missing the baseline year, right?
Yeah.
What does it start with? An action verb, to increase, right?
Yeah.
So that's good. We know what direction we want to move. We're moving in, increasing, decreasing. Okay. What's the health issue? What's the outcome? What are we trying to change here? The measles immunization rate. Who's our priority population?
But it doesn't say like where.
But it doesn't say the place, right? So we know it's 2 to 3 year old children, but is it in the US? Is it in Nigeria? Is it in Johnson City? We don't know, right? It has the baseline rate, but without the baseline year. And then it has the desired future rate, and the time by which we're expecting to achieve that rate, right? The proposed magnitude of change, is that reasonable, attainable, right? The A in SMART, attainable. What do you think?
I guess you can't determine that because you don't have the baseline year.
You can't determine that because you don't have the baseline year, right? It makes it difficult to determine if a 20% point increase is attainable or not. If we have 5 years to attain it, perhaps yes. If we have 1 year, perhaps that's less attainable. So that's why it's important to have the baseline year. Okay. So how can we improve on this objective?
Add the location and the baseline.
By adding the place and the baseline year. Okay? How can we determine if the proposed, assuming we know the year, let's say this is 70% in 2016, assuming we know the baseline year, how can we determine if the proposed magnitude of change is attainable, reasonable, or not? Based on what? Yes, ma'am.
You can look at other programs that have done that, maybe in similar areas, and see what their successes were.
Exactly. You can look at the literature, look at other programs in similar population or similar area, and you want to look at programs that were well designed and implemented, right? Because they can provide a benchmark for you. So that's very important. Benchmarking against other programs. What else would determine what you propose as your magnitude of change?
If you look at wherever they're at, like the previous data, and see how long it took them just to get to 70%.
Exactly. So you can look at the trends over time, and actually you can see Healthy People 2020 objectives. Many of them, the target level is established based on trend analysis. What else is important to consider in establishing a magnitude of change? Yes.
The kind of resources you have available.
The resources that you have available. Did you take this course before? Okay. The resources that you have available to you. Okay. And resources defined broadly in terms of human resources, budgets, and other types of resources. Obviously, the more resources that you have, the greater impact you can expect. Okay, so with that in mind, work please on the second and third objectives.
That's fine. Yeah. So I'll send you the numbers, like, probably if one year is well, I guess I'll get yeah, so what happens? I don't know. That's what he said. So it's, I was like,
Okay, objective 2. Heather, can you please help us with objective 2?
So we thought it was a smart objective because it has the baseline, it has the time period, and it has the percent as to what you want to do. Oh, but it doesn't have who it's affecting. So I guess it's not.
Can everyone hear Heather? Okay. You guys have to speak louder, you know.
Okay, so it is not a smart objective because it doesn't have the who you're wanting to decrease the prevalence of smoking.
Okay, so it does not specify
Who?
if we're trying to decrease the prevalence of smoking cigarettes among everyone in the state, or just among men, or just among women, right? Or among the youth, or what population group? Okay, what else? Other thoughts about this objective? You had raised your hand.
Oh, it was to point out that it doesn't say who.
Okay. Any other thoughts about this objective? Yes.
The time frame and the amount you're bringing it down could be called into question because that's a very large change in a relatively short amount of time.
So this is actually so this magnitude of change is the proposed magnitude of change is likely unattainable given what we know about cigarette smoking. Okay. If this was immunization, for example, it would be a different story. You can do mass immunization campaigns and immunize large segments of the population within a short period of time. But changing smoking behavior is not an easy thing to do. Especially if this is prevalence, measuring prevalence, not, for example, it's not measuring youth who start smoking. Okay, that you may be able to reduce faster, but to see a change in the prevalence in the population, that's a huge change, and yes, likely unattainable. The third objective. Faye.
Okay. Okay, that doesn't tell us actually where we're coming from, like the baseline, to let us know how 90% would be possible. We have the parity population, we've been given the age range. Then, what else? Okay, we have the output, we have the 90%, we have the year, but we don't have where we're coming from, like I said here, so like, that's it basically. Yeah, that's it.
So no baseline, right?
Yes.
It's pretty specific in terms of defining the population, you know, residents of Washington County, ages 40 to 60 years. So it's quite specific there in terms of defining the population and the target level and the target year, but it's missing the baseline level and the baseline year. So there really is not going to be a way to assess, again, the feasibility or the attainability of this objective. Okay, a couple more.
Have you applied for Minnesota? Hey, this, they get it. You won't even know, it's very motivating. What is, a lot of times bigger. And it's Snickers or Snickers. Snickers. I want to say Snickers. Also pepper. Yeah. I mean, majority of older fucking companies, their insurance companies like air. Yeah. Like liberals for chicken. Most of the time I just read the accent. All day. Well, you should go log for your class because it's they're interesting. It's just a group of yeah, they just all the older people go. Just know they're just on a picture.
When I was going to water last year and always seeing in water aerobics class, like that's all I want to do. It looks so much more enjoyable. I've done it once and it's really good. I want to do it sitting and trying to say it's literally just in general. Yes, I'm gonna try. Like so much more have you ever seen yoga on waterboard? Yeah, like I think there's actually a class. Yeah, dude, I've seen that. What is your go yoga? Oh, yeah. Let's do that. I bet you can find it. He basically essentially like put yoga and you can like hit yoga and it's really bad. But I would try this
Okay, let's start with the easier one. Which one is the easier one? Number 5 is actually the easier one. Because number 4 is a hot mess. Okay, number 4. She wants to start with number 4. So we're gonna have you help us with number 4.
Okay. So number 4 says who and where, and that's about all that's going for it. It doesn't have any measurable data. We don't know percentage, baseline, target, the year. All we know is they want to promote exercise among elderly residents of Sullivan County. So it's missing pretty much every other thing.
So what does it look like? Does it look like an objective?
It looks like a mission statement.
It's like a mission statement.
It's like a goal.
It's like a goal, right? A broad goal, not a specific objective. Remember again last week we talked about broad goals and specific objectives. This looks more like a goal, so under which you might have again specific objectives. So it will take a lot of work, to transition it to an objective. How about number 5? I'm looking at you. You're going to help us with number 5. My friend there. You're looking at me too.
Oh, number 5? I'm looking at number 5. One problem with number 5 is that we don't know the timeline in which they want to do it. We don't know the baseline, and we don't know between what years. And we also don't know, like the baseline, we don't know what data came before at the time.
Okay. So how might a better objective look like? Can you rephrase it for us?
The objective of this program is to increase the proportion of Tennessean children's ages 5 to 14 years who always use auto seatbelts. You can say I don't know, the figure you can say from like whatever the figure was in 2015, and we're changing it by 2018 or something like that.
So from 70% in 2016 or 17 to,
Like, I don't know, you can do 80, yeah, 80%.
to 80% by
2018,
2018.
2019.
We need to give those objectives time, right? I mean, because every objective we're going to have to implement different activities, to reach it. And we will talk about those time frames in just a minute. But again, the purpose here is really to appreciate the importance of writing smart objectives. And again, you're going to be doing that for your project. And unless you write smart objectives, develop smart objectives, you really cannot, again, evaluate or measure the impact of your objective. The second phase of the program management cycle involves an in-depth review of the literature. So at this point, you have, again, developed your problem statement, you have developed your desired outcome objective, stating the future desired level of your health problem. Now you're going to take a deep dive into the published scientific literature in order to identify the risk factors for your health problem, and also in order to identify state-of-the-art interventions addressing your problem that have been found effective. So there are two main purposes for reviewing the scientific literature. First, identifying the risk factors influencing your health problem, and second, identifying, again, evidence-based interventions that have been proven effective in addressing your health problem in other communities or with similar populations. Yes, ma'am.
What if there are no examples that you could pull from that, like, at that point, are you just kind of doing your own little experiment intervention program?
Exactly. So if there are really no evidence-based interventions, you will develop an intervention. And there's a whole science, for developing a new intervention. You would develop it as a pilot intervention, meaning that you would implement it on a small scale, okay, with a segment of your priority population, okay, and evaluate it, again, see what works, see what doesn't work, improve on it, and then extend your reach as indicated by the evaluation.
So you're basically doing the same things, just smaller scale.
Right. And again, there is a whole, science for developing, new or novel interventions. Because that does happen. It's a good question. That happens all of the time. Now, where would you find evidence-based interventions? There are two very helpful resources that you should be very, very familiar with as public health students. One of them is called the Community Guide to Preventive Services. And the Community Guide lists evidence-based, population-based interventions for different health conditions. Remember, population-based interventions, community-wide interventions. The Clinical Guide, the full title is the Clinical Guide to Preventive Services. The Clinical Guide lists or identifies evidence-based clinical prevention interventions for different health problems. Okay? So depending on whether you are planning to develop a community-wide population-based intervention or an individual-based clinical intervention, you're going to want to consult either the Community Guide or the Clinical Guide. Those are available online for free. Okay? and they do a very nice job, again, of summarizing the evidence related to different interventions for different problems. So when you are doing your project, again, there is really no need to reinvent the wheel. Chances are there have been evidence-based interventions addressing your identified problem. Now, you might need to tweak them, adapt them for your specific population, but you may not need to start from scratch. So again, there are two purposes for conducting the scientific literature review: identifying evidence-based interventions addressing your problem, and identifying the risk factors influencing your health problem. And this is how a typical analysis of those risk factors would look like. So for any health problem, again, let's say your health problem is breast cancer mortality, or your health problem is, teen pregnancy rates, or suicide rates among college students, or cardiovascular disease rates in Appalachian communities. Whatever your health problem are, you want to identify the different, again, risk factors affecting it. And the risk factors exist at multiple levels. The determinants are the risk factors that directly influence the level of your health problem. So the determinants are the risk factors that live very close to the health problem, such that a change in the level of the determinant will lead to a change in the level of the health problem. The direct contributing factors are also risk factors, but they directly influence the levels of the determinants. And the indirect contributing factors are also risk factors that are community specific, that influence the levels of the direct contributing factors. Okay. So let's take a look at an example, because it's always easier when we can look at an example. So in this example, our problem is neonatal mortality. What is neonatal mortality?
That's a group of newborns less than 28 days.
Exactly. So a neonatal death is a death during the first 28 days of life, right? So the neonatal period is actually the most vulnerable time for a child's survival. Children do face the highest risk of dying in their first month of life. The average global rate of neonatal mortality is 18 deaths per 1,000 live births in 2017. So across the globe, the average global rate was 18 deaths during the first 28 days of life per 1,000 live births in 2017. What is the most common cause of neonatal mortality? Low birth weight or preterm births, right? That's the most common cause of neonatal mortality. Actually, about 1/3 of neonatal deaths are related to preterm birth or low birth weight. So low birth weight as such is a determinant of neonatal mortality. A change in the level of low birth weight rates, a reduction, a drop in preterm births and low birth weight rates will result in a drop in neonatal mortality. Another determinant of neonatal mortality is are the weight-specific mortality rates. So really, treatment interventions that promote life among low birth weight infants. So from a public health perspective, if we were to design an intervention to address neonatal mortality, which determinant do you think we will focus on? Decreasing low birth weight rate or developing treatments to help low birth weight infants live longer? Low birth weight rate, right? I mean, this is really more in the medical realm, in the biomedical realm. This is a treatment intervention, again, whereas this is a preventive intervention. Now, if we have all of the resources in the world, we can do both, but typically resources are limited. Okay, so we have to decide on the intervention that will, again, generate the greatest impact on our outcome or the greatest return on the investment. Once we identify the determinants of the health problem, now we need to identify the direct contributing factors that impact the determinant with which we want to intervene. So what are those factors that affect low birth weight? So in this example, tobacco use in pregnancy, low maternal weight gain, and inadequate prenatal care are among the major suspects, right? So again, those are key risk factors that we know from the literature, from the evidence, impact preterm births and low birth weight rate. So we should not be guessing what those factors are. Again, we should be identifying those factors from the literature. So women who use tobacco or other substances during pregnancy are more likely to have preterm births and low birth weight infants. Women who start prenatal care late or receive inadequate prenatal care are also more likely to have low birth weight infants. And pregnant women who do not gain the appropriate weight during pregnancy are at risk of low birth weight. So those are then the direct contributing factors. Okay? A change in the level of those direct contributing factors will lead to a change in the level of the determinant, which in turn will lead to a change in the level of neonatal mortality. Determinants and direct contributing factors are universal. What does that mean? It means that in any community around the world, low birth weight impacts neonatal mortality, and in any community around the world, tobacco use in pregnancy, low maternal weight gain, and inadequate prenatal care impact low birth weight rate. So those, again, determinants and direct contributing factors are universal. Indirect contributing factors, the ones at the bottom of the slides, those are community specific. Okay? So again, once we identify our determinants and direct contributing factors, we should identify those risk factors that are specific to our community that impact the level of the direct contributing factors. So whether a woman uses tobacco during pregnancy or not is influenced by access to tobacco in our target community, by whether or not there are tobacco education or cessation programs during pregnancy in our community, whether a woman receives early and adequate prenatal care is influenced by whether or not she has access to healthcare services in our community, by the availability of transportation and daycare services for her current children so that she can seek prenatal care. And similarly, weight gain during pregnancy is influenced by a woman's access to healthy foods, and to government programs such as WIC that provide nutritional services to pregnant women. So the indirect contributing factors, again at the bottom of the slide, are community specific. It may be easy or difficult to access tobacco products in our community. We may or may not have tobacco cessation programs for pregnant women in our community. Health insurance rates may be high or low in our community. Transportation services to healthcare providers may or may not be available in our community. So one thing to keep in mind is we do this analysis sort of backwards. We start by, again, identifying our health problem. Our health problem in this case is neonatal mortality. We take one step backwards and we identify the key determinants of neonatal mortality. We take another step backwards and we identify the direct contributing factors that impact those determinants. We take a third step backwards and we identify the indirect contributing factors that impact the direct contributing factors. And don't ask me to repeat that because I want to hear it. But that's the idea. Okay? You start with the health problem and you sort of do a backwards analysis of the risk factors. Now let me ask you this, if you're designing an intervention to impact neonatal mortality, where are you going to start? Your intervention is going to address what? The determinants, the direct contributing factors, or the indirect contributing factors? The indirect contributing factors. So your intervention is going to seek to limit access to tobacco or provide cessation programs for pregnant women or increase access to healthy foods for pregnant women or provide health insurance to pregnant women. So you're going to try to influence, again, those community-specific factors in order to change the level of the direct contributing factors, leading to a change in the level of the determinants, ultimately leading to a change in the level of the health problem. So you do the analysis backwards. The analysis proceeds of the risk factors, starts with the problem, then identifies the determinants, the direct contributing factors, and the indirect contributing factors. Then you design your intervention forward. You address your intervention, you address the indirect contributing factors. If you address the right factors and do it right, you should see a change in the level of the direct contributing factors, which again should lead to a change in the level of the determinants, ultimately changing the level of the health problem. So how do we come up then with objectives for our intervention? So we've analyzed our problem for its risk factors. We have determined that we want to intervene with this determinant, low birth weight rate, not weight-specific mortality rates. Now we have to develop objectives addressing each of those factors. How do we go about doing that? So how many people here have access to the internet? Or if you work in groups of 2 or 3, can you guys go to the Healthy People 2020 website? So let's go to the Healthy People 2020 website.
It's literally everyone just like skidding right next to
Yeah.
Like it's literally just us. Like her just
Yes, we are.
Yeah.
We're all also having the same problem, so.
Oh, good.
Yeah, we're just like crashing the living people.
Maybe everybody's on it too.
Stop it.
So no one is able to access it? We have the People 2020 website? You are?
I can't. She got it first.
Yeah, try again.
It's literally just. I was seeing if there was like another website.
Okay, I'm not able to access it from here for some reason. Are you guys able to?
No.
Okay. That's fine. But okay, if you just look here at what's on the screen, you can actually see that you will be able to. You should be able theoretically to search.
That's a B.
The 2020 topics and objectives. And neonatal mortality. I was working last night when I did all this. Neonatal mortality falls under the topic of maternal and infant child health. So there are different, again, topics in Healthy People 2020.
It's literally just that website.
Just that website?
Yeah. Because I was able to pull up CDC's Healthy People 2020 just fine. So I did just the website. It's just the Healthy People website.
Okay, that's okay. So what I was going to show you are the different objectives in Healthy People 2020 related to neonatal mortality. So this is how the topic areas are, again, in Healthy People 2020. There are 42 different topic areas covering pretty much all major health indicators. And so again, neonatal mortality would fall under topic number 26, which is maternal, infant, and child health. And there are different objectives there related to the neonatal mortality rate, the objective for neonatal mortality rate in the US, as well as the other risk factors. So for neonatal mortality, again, the objective that we will develop will be called the outcome objective. And this will seek to reduce the level of the health problem in our population. So it will be something like to decrease neonatal mortality rates let's say we're working across the US, in the US, from the current level, which is about 5 deaths per 1,000 live births in 2010 to 4.5 deaths per 1,000 live births by 2020. What do you think of this objective? Is this a smart objective? Okay. What's the time frame? How many years? 10 years. So outcome objectives addressing the health problem are typically long-term objectives, typically between 5 to 10 years. Because it will take time to see a change in the level of the health problem. Remember, we have to first intervene with the indirect contributing factors, see a change with the direct contributing factors, then see a change with the determinants before we can see a change in the level of the health problem. Okay? So outcome objectives, again, are typically long-term objectives, 5 to 10 years. We will also develop an objective for our determinant. What is our determinant? Low birth weight rate. By the way, if you're interested, if you're able to find Healthy People 2020, the outcome objective for neonatal mortality, it's MI, maternal and infant child health, objective number 1.4. Just FYI. Low birth weight rate, the objective for the determinant is called the impact objective. So the impact objective is going to be your objective addressing the future level of the determinant in your priority population. So can someone help me develop an impact objective addressing the future level of low birth weight rate in the US? What's the first word in our objective? What's the first word? 2. At least we can do that, right? We've been doing this for an hour. What's the second word in our objective? Decrease, right? We want to decrease low birth weight rate. Anyone disagrees with that? Does anyone want to increase low birth weight rate? Okay. So to decrease what? Low birth weight rates. Where? Where? What did we say in the outcome objective? What did the outcome objective say about where? In the US. So what should the impact objective say? In the US. They have to be the same population. Okay? All of our objectives have to have the same population. We can't intervene in Canada and expect to see a change in the US. Okay? So to decrease low birth weight rates in the US, what's the word that goes next? From the current level, and I was actually going to show you the actual current level if the internet cooperated.
The CDC has a mid-course
Mhm.
progress for,
What does it say?
let's see, their baseline value was 4.5 and the mid-course value was 4.0. they did see, but,
For neonatal mortality or low birth weight rate?
oh, for the 1.4 goal.
Yeah. How about for low birth weight rate?
I'll come back to you on that one.
Let's just say from the current, let's say that 10% of infants are born with a low birth weight rate in what year? What's our baseline year? 2010, so it should be the same baseline year for all objectives, preferably. 2, %, by when? By 2020? Should we achieve our impact objective earlier to be able to see a change in neonatal mortality? We really should achieve our impact objective earlier, because it's going to take time for the change in low birth weight rates to translate into a change in neonatal mortality. So let's say by 2016 or something like that. So impact objectives are typically intermediate in terms of their time frame, typically between 1 to 5 years.
Okay, so they said it was 8.2% in 2007 and it's 8.0% in 2013.
Okay.
So, and they have it as improving.
Okay, so I wasn't too far. So now we have our outcome objective, our impact objective. We also have to develop process objectives for each of our direct contributing factors. So typically you're going to have multiple process objectives, at least one for each of your direct contributing factors. And they're going to be, again, developed as SMART objectives. So to decrease the proportion of pregnant women who use tobacco during pregnancy from the current level in 2010 to the future desired level. Or in the case of prenatal care, to increase the proportion of pregnant women who obtain early and adequate prenatal care from the current level in 2010 to the future desired level. Your process objectives are typically going to be short-term objectives, 1 to 3 years in terms of time frame. Because again, you want to achieve your process objectives first in order to see a change in the level of the determinant, and later a change in the level of the health problem. So again, outcome objectives are long-term objectives, 5+ years, 5 to 10. Impact objectives addressing the determinants are intermediate in duration, typically 3 to 5 years, and process objectives addressing the contributing factors are short-term objectives, typically 1 to 3 years. when you get a chance to access Healthy People 2020, the impact objective related to low birth weight rate is gonna be MICH number 8. Maternal and infant child health objective number 8. Related to tobacco use in pregnancy, MICH number 11. Related to low maternal weight gain, MICH number 13. And related to prenatal care, MICH number 10. Okay, so actually in Healthy People 2020, there are objectives for each of those risk factors. Again, for the nation to achieve by 2020. Now, 2 important caveats. When you're working on program development, it's unlikely that you're going to be working on a national program. Okay, you're going to be working on a state-wide program or a county-level program or a regional-level program. So it's important for your baseline data to use state-level data as available or county-level data. Okay? Because your state-level data or county-level data or regional-level data will likely be different from the national data. The national data is an average for all 50 states. There will be some states whose performance mirror the national levels, but you need to be accessing your state-level or county-level data to develop your objectives. The second important thing to note is the Healthy People 2020 objectives. They all have a time frame by 2020, just because it's Healthy People 2020. But again, in reality, when you are designing outcome, impact, and process objectives, they need to be long-term, intermediate, and short-term. So just keep those 2 things in mind, as you again review the Healthy People 2020 objectives. Yes.
I wanted to ask, why do some interventions go from input to process to outcome then to impact? Because in this case, we are going from impact to outcome.
Yeah. So that's a great question. So there are really different contexts, different fields where the terms are switched. They use impact for the outcome and outcome for the determinant. It's just a switch in terminology. In practice, it really means very little. I'm using an approach where the outcome objective is just tied to the health problem and impact is tied, to the determinant, which is very common in the literature. But yeah, increasingly you see impact objectives addressing the level of the health problem and outcome objectives addressing the level of the determinant. It's just a change in the terminology, but the process is still the same. And the way you develop those objectives is still the same. But that's an excellent question. Other questions? Okay, so I know it's late in the afternoon, but I want you to scratch your heads a little bit and let's work on something together. I've talked a lot today about breast cancer mortality rates. Let's see if we can analyze this health problem together. What would you say is a major determinant of breast cancer mortality rates?
Genetics.
I'm sorry?
Genetics.
Genetics.
Yeah.
Okay. What else?
Lifestyle.
Major determinants, where a change in the level of the determinant will lead to a change in the level of the health problem. That's lifestyle.
Stage of diagnosis.
Stage of diagnosis.
Stage at like what stage you're at when you're diagnosed. So like
Exactly, and that's determined by what largely?
access to screening.
By screening rates,
Yeah.
right? So mammography or breast cancer screening rates are a major determinant of breast cancer mortality. An increase in mammography rates will lead to earlier diagnosis of breast cancer, more effective treatment, and a reduction in mortality rates. Another determinant is how effective the treatments are. So treatment effectiveness. Okay. From a public health perspective, again, if you're designing an intervention to decrease breast cancer mortality rates in your community and you have limited resources, you have to select one of those determinants to address. Which one would that likely be? Screening rates, right? Increasing breast cancer screening rates. What are the direct contributing factors that impact screening rates? Again, think factors that will directly influence the level of screening rates.
Ignorance.
I'm sorry?
Ignorance.
So,
Education.
exactly, so education or awareness, right?
Access.
And access to screening. Good job. Ah, no. Bad job. Access to screening and education or awareness about breast cancer and mammography screening. Okay? So again, that's our health problem. Those are the determinants, and those are the direct contributing factors of the screening rates determinant. Now, what are the community-specific indirect contributing factors that impact the level of women's awareness about breast cancer and screening? I'm sorry?
Or health education programs.
Health education programs or awareness campaigns. Very good. What else?
For the access to screening, would it be like what technology a healthcare place has access to? Because some offices have better screening methods than others.
So availability of
resources
or technology, or just even availability of mammography facilities, right?
Yeah.
Rural.
factors.
I'm sorry?
Economic factors too.
Impact access to screening?
Yes.
Okay. What else impacts access to screening?
SES.
SES, I put that there. What else impacts access to screening or to healthcare in general?
Transportation.
Transportation. And health insurance coverage, right? And education awareness is also impacted by provider counseling, so doctors, nurses, counseling women. Now again, notice the determinants and the direct contributing factors are universal. So in any community around the world, an increase in mammography rates should result in a decline in breast cancer mortality rates because of early identification of disease and more effective treatments at early stages. And in any community around the world, higher levels of education and better access to screening should improve screening rates. Whereas those indirect contributing factors are, again, community specific. In our community, we may or may not have health education programs specific to breast cancer. Mammography facilities may or may not be available. Insurance rates are going to vary by community or population, etc. So again, you will develop an outcome objective addressing the future level of breast cancer mortality. If you are looking in Healthy People 2020, that will be objective C3 under the cancer topic, C3. And you will develop an impact objective addressing the future level of screening rates in Healthy People 2020, that will be C17. Now, let me ask you this. You've developed outcome objectives, impact objectives, and process objectives. Now you have to develop activities, tasks to implement, to achieve those objectives. Which objectives do you develop an action plan for? Meaning activities and budgets and time frame. Do you develop action plans for your process objectives, for your impact objectives, or for your outcome objectives? For your process objectives. Is anyone not clear as to why that's the case? For every process objective, you will develop an action plan that includes the activities that you will implement to change the level of that process objective. So for your process objective related to increasing awareness about cancer and screening, your activities are gonna involve developing health education programs or encouraging providers to counsel their patients about cancer and screening. For your process objective related to access to screening, your activities are gonna seek to increase the availability of mammography facilities in your community, provide transportation to women to get to the mammography facility, or make sure that the health insurance policies are covering screening at no cost, or increasing the proportion of women who are insured. Okay? So your activities, your action plan, will tie to the process objectives. Again, if you implement those activities, if you targeted the right process objectives, the right contributing factors, you implement the activities, you should see a change in the level of the process objectives. Then with time, that by itself should lead to a change in the level of the determinant and the outcome, assuming you get this analysis positive. Okay? So my homework to you, my challenge to you, between now and next week, because we're gonna start here next week, looking at action plans. How do we develop action plans for our process objectives? What do we include in them? How do we develop a budget? And how do we develop an evaluation plan? So, your homework between now and next week is to do a health problem analysis for unintended pregnancy rates. And the guys will do that too. Not just the ladies. Okay? So the health problem is unintended pregnancy rates. And to help you out, look, I'm very kind actually, kinder than you think. Unintended pregnancy, you will find that in Healthy People 2020 under the topic of family planning. Okay? Again, there are 46 different topics. Family planning is one of them. Yes, ma'am.
Do you want this for the United States collectively, or you want this for the community?
The determinants, the direct contributing factors will be the same. Okay? Then the indirect contributing factors, if you can do them, for your community of your choice, that will be fine. But so and review all of the family planning objectives, because they will actually include your determinants, your contributing factors, and your indirect contributing factors. So they're all going to be there. You're going to have objectives already developed for the health problem, for the determinants, and contributing factors. But you need to figure out what's what belongs where, okay? So work on that. I have no idea who I'm gonna ask to come up here and show us their work at the beginning of class next week. And we will use that to then begin discussing action plans and evaluation plans. Any questions, folks, before we leave for the day? So again, we have two examples, neonatal mortality and breast cancer mortality rates. Try to follow that same reasoning, that same logical thinking to do the unintended pregnancy. Okay? Thank you. Have a nice evening, and I will see you next Thursday.
Oh, let me show you the No, I can just see your signature on her computer, and then from what I can kind of see, what